So welcome to the Northeast Telehealth Resource Center Summer Webinar Series. My name is Danielle Louder, and I am the Program Manager for the NETRC. I am about 3 months into this new position and have had the privilege of working with a phenomenal group of partners and meeting lots of folks throughout the region in my short time here. And I'm excited to be able to offer this great webinar series to you this summer. I'm just going to go over a couple of logistical things before I go ahead and introduce our speakers. I'm going to point out, if you are unfamiliar with Zoom or haven't used it in the past, a couple of icons. At the very bottom left-hand corner of your screen, you have a microphone. If everyone could please mute their audio if you're not speaking at the time, just so that we can avoid a lot of feedback during the presentation, that would be fantastic. If you are like many who are utilizing this time, and we would love to hear your feedback on this time, and you're having lunch and you don't want everyone to be able to see you having lunch, you can actually click on the video camera and that will stop your video. So we won't be able to see you in your location. So just wanted to point those two important icons out. And then the other important icon that I'm going to mention is down at the bottom middle of your screen. Oh, I'm actually getting some feedback here, so I'm going to mute someone. So at the bottom middle of your screen, there's a chat icon. If you have questions, if you have issues with technology during the presentation, or if you would like to ask one of our speakers a question during the presentation that we will address at the end during the Q&A session, you can simply click on that chat and it gives you a box to enter your question. You type it in, hit enter, and the speakers will be able to see, and in fact everyone will be able to see what your question was for the chat. So that is pretty much it as far as logistics. I'm going to give you a very brief introduction to the Northeast Telehealth Resource Center. Some of you are probably already familiar with it, so forgive me if this is a little redundant. But the Northeast Telehealth Resource Center team, I already introduced myself, includes Dr. Terry Rabinowitz, who is our principal investigator and a practicing physician at Fletcher Allen Healthcare, and along with our partner Fletcher Allen Healthcare and the University of Vermont. Judy Amor, who is on the webinar with us today, is our telemedicine grants administrator, and she is also out of Fletcher Allen in UVA. Michael Edwards, Dr. Michael Edwards, is our expert consultant and works with us for research and evaluation. It is just a huge plethora of information in regard to telehealth. Great asset. And I will point out that we actually have an open position, a project director position, which was previously filled by Kim Mohan, who took an incredible position opportunity with the New England Rural Health Roundtable. So we are looking for a great team member to fill that role. If folks are interested, they can feel free to contact me. I also need to mention that Medical Care Development Public Health, which is my employer, is our other partner along with Fletcher Allen and UVM in housing the Northeast Telehealth Resource Center. So what are TRCs? They are federally funded through HRSA and the Office of Advancement for Telehealth and their Office of Rural Health. The grant program was initially established in 2006. There are 12 regional TRCs all over the United States, which provide technical assistance and resources to their particular region. You'll see a map in just a moment that shows all of the different regions and where they cover, including our region for the Northeast. They have such extensive telehealth program experience. So if you have a question regarding telehealth, even if we don't have the direct answer here at the NETRC, we have a huge asset and partnership across the entire United States of people who have worked in every different realm of telehealth, whether it involves policy, protocol development, et cetera. We can find the answers for you. And we have two specialty TRCs, the Telehealth Technical Assistance Center, actually based out of Alaska, who provides great resources around the technology itself. And then we have a policy, the National Center on Telehealth Policy Center out of California, who does the same thing. They provide that specialty expertise specific to policy. And this is just the map that shows all of the different regions. In particular, we'll point out the Northeast and thank you for driving and showing that. We have one state you can see, New Jersey is gray. They have not had coverage through a TRC in the past, but we are very happy to say that we, along with the Mid-Atlantic TRC, will actually be providing technical assistance and resources to them in the next grant year, which we are very hopeful will be refunded starting September 1 for the next 3 years. And the mission of the Telehealth Resource Center simply is to work with anyone and everyone, organizations, individuals who wish to establish or expand a telehealth program successfully. We know that it is not easy. We know that there are a lot of moving parts. So our mandate really from the Office of Advancement for Telehealth is to assist healthcare orgs, networks, providers in the implementation of cost-effective telehealth programs. We all know that that's a huge barrier, and telehealth can really save time and dollars from the perspective of providers and our patients. So that's really what we're focused on, and it always really has focused on rural and medically underserved areas and populations, but as telehealth grows, we really hope that designation almost goes away and we're able to provide and help folks to implement telehealth no matter where we're located. So this is just a brief description of the types of services or resources that we can provide as a TRC. The nuts and bolts of implementation day to day, we can help with program design, protocols, best practices, workflow, because we know that it has to fit in with your existing system of workflow, reimbursement policies. Every state is different, where we try to keep our hands on the pulse of every different state that we work with. Equipment selection, we have great expertise out of Fletcher Allen with Harry Clark with that. Funding and sustaining your program, that's a big one. Specific clinical applications, we have, as I mentioned with Dr. Terry Rabinowitz, we have great expertise in telepsychiatry, behavioral health, palliative care, pediatric critical care, and we're always looking for new connections to find additional expertise so that we can help you all in moving your programs forward. I already mentioned connections with our peers nationally. We have access to all of these great resources through the other TRCs, reimbursement and other policy issues, and training related to telemedicine, because we know that that's a huge piece of it as well. It's not just delivering the care, it's learning how to do it and fitting it into our existing workflow. So without further ado, thank you so much to our speakers. I'm going to introduce them quickly. I won't do them justice, I'm sure, but we had some great information in our newsletter, which is how I'm hoping most of you found out about it. We're going to focus on behavioral health and medical remote care solutions for nursing home residents today. Our speakers are going to be Dr. Thomas Sheeran and Mr. Mark Treat. Dr. Sheeran is an assistant professor at the Alpert Medical School of Brown University and clinical psychologist at Rhode Island and Miriam hospitals. His research focuses on using telehealth technology to improve mental health services for seniors in community-based settings. His research has been funded by the National Institute of Mental Health, the Cornell Clinical and Translational Sciences Center, the United Hospital Fund, and Rhode Island Foundation. Dr. Sheeran holds adjunct faculty appointments at the Weill Cornell Institute of Geriatric Psychiatry and the University of Rhode Island Geriatric Education Center. Mr. Mark Treat has extensive experience with large-scale government contracting, systems integration, and project management. Mr. Treat comes to Nalari Health from SAIC, an $11 billion, 45,000-person science, technology, and professional service organization where he led the inception, sales, and development of a new business practice, including the successful negotiation of over $100 million in new contracts. Prior to working with SAIC, Mr. Treat led the strategy and planning practice for Commerce One, a leading internet services and online marketplace company. His experience includes working with online health information and exchanges, co-founding a bioinformatics company, co-founding a cell-based screening company, working with syndromic surveillance programs, and supporting the Johns Hopkins Center for Computer-Based Surgical Systems. He is a graduate of Babson College. And as I said, I will not do them justice, but we will have their PowerPoint slides available to all of you via PDF after, and I'll just have you email if you would like to have those. So welcome, and thank you so much, Dr. Thomas Sheeran and Mark Treat.
Great, thanks very much. What I want to do is, maybe just by way of broad introduction, is Mark and I have decided to kind of break our talk into our two separate pieces, with my piece of it really being more of, I guess I would call it maybe a case study in a telehealth application for geriatric residents in long-term care settings. I'm going to focus on the clinical need, the clinical model, and the clinical service delivery model. And then I think I'll talk a little bit about the technology platform as an example, but then I think Mark will then, for his portion of the talk, speak about the broader issues, the systemic issues, the implementation issues, and can also speak to some of the broader applications for the clinical and the service delivery model. So that said, my particular work focuses on geriatric mental health services, and I am particularly interested in finding ways to improve mental health services to seniors in the community settings where we most often find them. As was mentioned in the intro, I'm a clinical psychologist by training, and most of the time people come to your office and they check in and they come back to your office and you sit down and you do 45 or 50 minutes of therapy, or if they're meeting with a psychiatrist, they might do an hour intake or a 15-minute med management visit. But for nursing home residents or homebound elderly, it's not so easy to just come into the office. So I'm going to talk a little bit about that. Speaking to the need, we know that the prevalence of depression and other behavioral health problems, by the way, but my area of focus is on depression, is quite high in long-term care facilities. The estimates vary widely, but the low has been around 20%, which is almost a tenfold factor from the general community, up to the majority, up to as many as 80%. We know that depression not only causes poor quality of life and a lot of emotional pain, but it affects all the other health outcomes. I always joke that I can, or comment I should say, that I can find the depressed patients in a nursing home just by going to physical therapy and asking them which of their clients are not adhering to their PT exercises and programs. They don't comply with PT, they don't follow through on OT, medications. In nursing homes, medications is less of an issue, but for assisted living, homebound elderly, it's an issue, wound care. And depression has been linked to increased adverse events, falls, hospitalizations, costs, and these patients have poorer medical outcomes and higher mortality rates. A lot of times when we talk about depression, suicide and suicide risk is an issue, and it certainly is. And in fact, the highest rates of suicide are not among teenagers, but among men, Caucasian men over the age of 85. But these patients, residents, not only have higher mortality rates from suicide, but they die sooner from all of their other medical illnesses, diabetes, heart failure, all of those illnesses that are common in older age usually lead to higher mortality rates when those patients also have depression. So the big piece about the work that we try to do is how can we get the right service to the right people in the right place and at the right time. And if you're involved in telehealth at all, you probably have seen a map something like this in some form or other. This is the HRSA health professional shortage areas for mental health. Basically, anything that's not white is designated as a rural or an underserved area. And the majority of it is in rural regions, and usually what indicates the need for services is either the population is too far, distance-wise, from a provider, or there's not enough specialists or providers in the region to be able to provide services. But access to health service isn't just about geographic location or whether or not the patient is in a rural location. When you think about a rural location, the service may not be available, and that's where telehealth can certainly come into play. Adequate density of providers is one issue. Non-rural and rural regions, though, may have utilization issues and barriers to utilization that may not be captured by that HRSA map that I showed you. Again, some of the population we're targeting have significant mobility issues or have cognitive issues, physical and sensory issues, so they can't just get in their car or can't just have somebody drive them to the doctor's office. And even if they can, they may or may not be able to find parking. And then ambulating to the office. Is the office wheelchair accessible? All of those things really impact their access to services. A few other factors impacting access to services and utilization of services is simply the demographics. There's the demographics in terms of providers. There's not enough providers out there. And that's true even of the urban settings and the community settings. As I mentioned, transportation to the clinics. Behavioral health issues include other problems such as substance abuse among the elderly, delirium, agitation, psychosis, anxiety, and some of these behavioral challenges become higher priority, particularly in long care settings where confusion, agitation, delirium pop up, because those are the most disruptive ones. And so a lot of times those become the higher priority conditions. So while you may have a large population of depressed clients in these settings, many of them are not getting attention because the higher priority conditions are drawing the resources, and there's not enough providers to provide services for everyone. So that was one of the things we wanted to address, was how can we, if you will, provide services for the quietly depressed residents in these facilities. So this project was about trying to combine two key components of service delivery. One is combined with what's known as collaborative depression care management, which has been well researched over the last 20 years. I think last count there were well over 30 randomized trials documenting the effectiveness of this model, which I'll talk about in a few minutes. Combining that with remote consultation to provide geriatric mental health expertise to the facilities and the depression care management person on site. So very briefly, this is kind of the model for collaborative depression care. On the left-hand side, you have the primary care doctor, the internist. At the long-term care facility, it could be the medical director. And then you also have a mental health professional who may be providing services to the client either directly or through an outpatient office through a family member. And these two providers may or may not collaborate, depending on many factors. And then what you have on site is a depression care manager. And the depression care manager could basically be any number of professionals. It could be a nurse, it could be a social worker, it could even be a physical therapist or an occupational therapist. As long as they're trained up on the basics of depression assessment, screening, depression treatment, providing the capacity to communicate with other providers and the capacity to provide some basic education. Any of those professionals have the capacity to be trained up in this area of depression care management. And then interface with the patient. So what you have is somebody on site who has a skill set in depression care management, who really serves as the frontline person in working with the patient. And then that depression care manager evaluates the patient's status, communicates with the other providers about the mental health status and the depression health status of the resident, and then works with the other professionals to come up with a treatment plan and to work with the resident with that treatment plan, provide education, support, guidance, and monitoring to the resident, and then serve as the communication, center of communication with the other providers. So again, our goal was to target the lower priority residents. In this particular case, we have a social worker who serves as the on-site depression care manager, and then we provide remote consultations to the resident, to the provider, to the depression care manager, and then they take kind of the lead in providing services. Just briefly, this is kind of a few screenshots from the Nalari Health platform, and as you can see, this is the way it works in this particular intervention is the social worker, the depression care manager, sets up an appointment with myself. We also have a geriatric psychiatrist who's available. And when we have the appointment, they basically either bring the laptop into the patient's room, the resident's room with them, or they go get them and bring them to a teleconference room. It's usually a conference room that's just set up with the laptop and the audio. They go to the website, log in, they see their providers below. They can set up the appointment virtually. In this particular case, we prearrange the appointments to a particular time. And then from the provider end, this is what it would look like for me, is you have a waiting room and you can have patients in there waiting for an appointment. And if they log on before I do, then I'll see them there. And if not, then they might see me on. They can tell if I'm online as well, if I allow that. I can also search for patients by name, by patient ID in the database. Can look up prior notes by myself, or if there are other providers who are using it, they'll have clinical notes as well. And then I can basically, once I see the patient, I can click a button to connect with them. And this is kind of a screenshot of that interaction. Now, what you'll see is there's a small window here where I would see the resident, and then there's a little picture of me there. This can be expanded to an HD where there would be a full screen for me and for the person at the other end, so that I would fill up the entire screen. That's helpful for some of the residents who might have visual problems. It can also be set up with headphones for auditory problems. Obviously, they need to have certain minimal capacity for doing these consultations, so their cognitive status has to be relatively intact. Although you could do it with folks with a fairly mild cognitive impairment and still be successful at it, as long as they can hear you, understand you, and can articulate back to you. You'll see on the right-hand side, you can also pull up notes, history, information while you're doing it. And you can either use digital audio for communicating, or you can actually call directly. I've been using a teleconference line, which we usually do just using a regular phone line, but it also has a capacity to dial through the network as well. And then the service delivery options are not just, certainly with a lot of these folks that we've worked with, I've done virtual consultation, clinical, virtual psychotherapy, if you will, with them. But you can also talk directly with the care manager, provide support, consultation to them, provide guidance on next steps. Working with family members can be done this way as well. So billing issues aside, there's a number of different ways that you can make use of the system to better provide services. Or you can do a combination of the two, which is often the case. So I'll end up talking with the resident and then talking a little bit with the depression care manager, and then often there's a follow-up call to someone on site or to a family member. So the idea here is a couple, just to recap, is to basically increase the skill base on site by training up the depression care manager, and then so that people who need the service have greater access to it, and then to support that service by using telehealth to provide consultation or direct clinical services. So far, so good. And I think our main outcomes are the usual suspects, I'll call it. Do people like it? Does care improve? Do the residents get better? And can we reduce emergent events? And then we've also been looking at it for transitional care for rehab patients, which has been kind of an interesting issue because there's more and more folks transitioning sooner out of the hospital and into rehab, and a lot of rehabs these days are at nursing home facilities. But one of the challenges that we're looking at is that the turnaround time, these patients a lot of times are not in rehab for very long. And so when it comes to depression care, which identification and treatment is usually over the course of several weeks, it's a little bit challenging. So there might be more of a screening model that we can implement. We're looking into that as well. So that's it from the clinical end. I'm going to let Mark take over and talk a little bit more about the broader issues from the technology and the service delivery for this and other populations.
Thanks, Tom. Appreciate that. So again, I'm going to kind of take a step up, maybe at a more of a 100,000-foot level, looking at remote care, telemedicine, telehealth, mHealth, whatever you call it, more as a system of care. And what I mean by that is an entire health system. So when we look at, what is it we're trying to do using, technology-enabled care models like remote care, it's really primarily about improving access to care, but it's also about the timeliness of care. In other words, being able to intervene when a patient is at risk or symptomatic versus, perhaps even weeks sometimes later for in-person care. We also look at things around maintaining relationships between providers and patients, and even providers and providers, to maintain the continuity of care as a patient might move from different care settings. And we also look at things about team-based care models, as a big push around patient-centered medical homes and other models that are designed to get providers to practice as a team and to coordinate and collaborate the care for a patient across various providers. Obviously, things we're trying to do is make healthcare more convenient and improve health outcomes, improve quality of life. But very importantly, as everyone on the call I'm sure is well aware, it's also looking at resource utilization and cost savings in order to justify a return on investment to make remote care work. But with that set of goals and that context, what we've tried to do is design a system of care. And when we talk about that, it enables a bunch of new business models. The way we like to look at it is we have a technology-enabled care delivery model where today in the market there are a lot of point solutions, but there's really an opportunity for somebody to pull it together into an integrated solution. And we've got to come up with clinical and delivery models that are scalable, and I would argue that should be targeted to specific subpopulations. In other words, if you were to create a remote care benefit for a particular targeted population, it may be very different than another targeted population. Tom was talking about residents in nursing homes. We also think about, for example, developmentally disabled populations. We think about folks who are in assisted living, folks who live independently, and also folks who are lower risk. So based on those settings, what is the appropriate use of remote care to deliver a holistic care model to that patient population? Other things that we think about is the staffing model. Not only the remote physician staffing, but the staffing within one of the care settings in terms of the ability to telepresent patients, how you would make sure that there's enough supply of services in the system, again, designing to minimize time to intervention. And we also spend a lot of time thinking about payment models. Obviously, there's a global move away from fee-for-service to other types of payment models. And how does telemedicine or a remote care model overlay to that evolution? And we have some strong opinions about that we'll talk a little bit about. So again, I'm thinking about it not as a technology system, but as an entire technology-enabled healthcare system that includes staffing, clinical models, payment, everything to do with the delivery of care. When we try to draw this on a single page, this was our best attempt. And if you can think about it here, in our case, we're targeting high acuity patients that are high risk that generally don't self-present. So we have up in the upper left corner, patients and their caregivers presenting to a panel of physicians through a system, and those patients live in a variety of settings. And our targets, they tend to be in nursing homes or adult day center, group homes, assisted living. To the extent our targeted populations that we're currently working with live at home, they have either a home health aide or a visiting nurse. One of the concepts that we've been working hard about is how do you have command and control of that remote care delivery system. So we've designed if you can think of it as a pod, and that pod performs 4 primary functions. The first is let's just call it in the enrollment or the onboarding set of processes. When we bring somebody new into our remote care system, we onboard them, we collect information, we get them into the system, we perform clinical assessments, we create care plans. So there's a whole set of activities that revolve around that. The second thing that we'll look at is monitoring of the patient population in 2 primary ways. The first, biometrically. Think of blood glucose and blood pressure and pulse ox and those types of devices that provide readings that tell people if they're red, yellow, or green. And we also do patient or caregiver reported outcomes. We ask questions. And those questions are designed primarily for two reasons. One, monitor compliance. You know, what time did Mrs. Jones have dinner last night? What time did you give her meds? What did she eat? Did she participate in yesterday's social activity? Did she go for a walk this week? All the different things that are in the care plan, we can ask and find out, you know, is that actually happening? And the second thing we're doing is a lot of the work that Tom does in terms of screening for depression or other potential acute mental health risks. So we'll ask questions about how patients are feeling or behaving in order to help identify at-risk patients. The third thing that we'll do is actual clinical interventions. And what we mean by that are meaningful clinical interventions where a remote provider is able to diagnose a situation or a patient and then prescribe a therapy with the idea that the caregiver in these settings to the right can receive those physician orders, for example, and treat the patient at the higher skill level of the physician. So it's really about connecting the caregiver to a higher licensed provider in a meaningful way so that they're able to diagnose and prescribe. And sometimes that's straightforward Skype-like consults, and other times it's using fairly sophisticated equipment that allows the remote provider to, for example, look inside of their ears, eyes, nose, and throat, or hear their heart through a digital stethoscope, or review an EKG or spirometry or what have you. So it's connecting those providers in a meaningful way. And then the fourth thing that really is looked at is the coordination of care. If you think of this as a remote health system that sits on top of a traditional face-to-face brick-and-mortar health system, those two systems need to communicate with each other. So in step one, when we're onboarding Mrs. Jones, we also find out who is her primary care physician, who are our specialists, and who are the other caregivers that Mrs. Jones consents to allow the coordination of care and the communication of care back to, for example, family members. So those encounters that are occurring remotely get captured in a system and are actually pushed back to the traditional brick-and-mortar care system, so those two systems remain synchronized. When we talk about remote care, we really think about it in three primary ways. This particular slide was done for a project with a developmentally disabled population. We had 1,200 developmentally disabled people who lived in 950 locations, many of which were group homes. And we only had a handful of nurses in a pod, for example, who are managing and monitoring their care. And we would train the direct service staff that would maintain activities of daily living for these clients and be able to present to the nurses using some of the more basic equipment. And the nurses, about 80% of the interaction was between the nurse and the direct service staff to make sure that client is getting the care they need and they're being monitored. And these are very, very complex patients with multiple comorbidities. The second scenario is if you think about it as a scheduled physician visit. So we would have an interdisciplinary team, might include cardiologists and pulmonologists and neurologists and primary care, and the nurse would schedule those patients into those remote visits as the nurse felt was appropriate. And we would buy that time on a service level agreement, again, going back to the staffing model component. So, for example, we might buy 10 hours a week from a cardiologist, but we would buy it Monday, Wednesday, and some Fridays from 1 o'clock to 3 o'clock so that the nurse is never more than 48 hours away from the ability to have a board-certified cardiologist review one of the patients and cases. So again, think of that as a scheduled visit. And then the third scenario is 24/7 on-demand urgent care. And the numbers are astounding when you work with some of the emergency departments who are doing this. For example, roughly 30 to 40% of the time for current people who are coming into the emergency room at Rhode Island Hospital and Miriam Hospital, for example, 30 to 40% of the time, those issues can be completely resolved with a direct service staff on the other end of the system, and the patient doesn't need to be seen at all. Another third, the physician basically says, this patient should be seen, but it's not urgent. You don't need to call the ambulance and bring them in tonight. Make an appointment sometime in the next few days with a primary care specialist again. And then roughly about a third of the time, they're saying this patient needs to come in immediately. So the point of that is roughly 70% of the encounters, there's value in connecting the caregiver to the urgent care in terms of reducing urgent utilization and even hospitalizations. So again, thinking about it as a holistic wraparound model in a system of care. Earlier I mentioned biometric monitoring. On the left here are just some examples of some of the devices that we use. And on the right are just some of the devices that we use to present a patient. Again, thinking about it as a meaningful encounter. It's not just talking to the doctor, but a doctor or other provider who can examine the patient remotely, diagnose the situation, and prescribe. Another theme that we're working on is, if you think about, it's particularly for these high acuity populations, there's a clinical team, and we're focusing on interdisciplinary models where you have multiple specialists. By the way, of which we believe mental health has to be one of the more important roles right next to and alongside the physical health. But we're also looking at how we use collaboration tools to extend it to some of the other caregivers for a patient so that they can collaborate and inform each other about what's going on with this patient in a HIPAA compliant and secure way. And that might include anyone from a family caregiver to a physical therapist to any kind of counselor that the patient interacts with. And what we've done as a company is we've made it a policy that if a patient's enrolled in one of our programs as a benefit, any provider to that patient can use the system for free to interact and treat that patient as long as the patient has consented, which we want to eliminate barriers to providing that integrated care model. Another thing, just on the topic of payment models, from our perspective, we're seeing an enormous amount of change, and today almost everything is fee for service. In our targeted population, we're seeing a major move towards capitation, but within capitation, we see a range from full patient global capitation to only capitating, for example, catastrophic risk or chronic care or some of the activities of daily living, or anything that we can contractually define as a benefit. And then you see all kinds of other incentive-based programs like bundled payment or value-based or shared savings models. So we're seeing a lot of things going on. As a company, we've really tried to start with a defined benefit approach, and we're growing into more sophisticated levels of risk and capitation, and we're also adding incentive payments. And you can see on a timeline that some of this is off to the right. And the big reason for us is that, and this may be a little bit politically controversial, I have some concerns about the incentive payment models because of the poor baseline data that you get from Medicaid and Medicare. One of the things we don't want to do is get a year into a program where we put a lot of risk into our payment model, and there's a lot of incentive tied to it, but yet a year later we're sort of disagreeing about how we interpret the numbers and what the real baseline is, et cetera, et cetera. So we wanted to design a program starting with a defined benefit and then growing into some of the other incentive-based programs and capitation models. This is a large and complicated topic of which if anybody who's on the line would be interested in talking more about, I'd love to have a conversation with you. So that's kind of an overall overview of the way we're viewing the world as a system of care. And I'll stop there, and I think we wanted to see if there might be any questions that have come in. So the first question that came up is, did you build this software or did you purchase it? And we, so at Nalari Health, think of us again as a systems integrator. In general, we are using third-party applications, and we are integrating other components to it and configuring it in a specific way. So we purchased the primary platform. What you saw, the screenshots that Tom showed was a software called American Weill, which is one of our partners, but we're partnered with about a half a dozen software vendors and about a dozen hardware vendors. Frankly, our approach to the market has been to be agnostic. In other words, if we go into a project and there's a customer who likes, say, Philips over, I don't know, GE, we'll go with the product that they prefer, or they may have an investment into and integrate to it. But we'll generally stay agnostic. The second question, what are the sources of funding for the payment for the clinician during the treatment outside of Medicare and Medicaid? We got a little back. So I'll talk to Nalari and then I'll let Tom talk. So we've got some demonstration programs underway that give us waivers from some of the standard Medicaid and even some Medicare requirements. So we're working under a couple waivers. We also have some commercial contracts with commercial health plans who happen to have patients who are at risk in the care settings that we're in. And we actually have done a couple things that are pure philanthropic or grant funded and or self-paid. So it's been a little bit of all of the above. We're working very hard to try to get Medicaid and Medicare under the integrated care contracts, the dual contracts that are coming out, to look at remote care as a benefit. We've had a lot of challenges where states don't want to pay for a certain benefit under Medicaid when Medicare, the federal government, gets the majority of savings because of the reduced hospitalizations for patients who are dual eligible. But as those integrated care contracts come together, it's essentially a three-way deal between the states, the federal government, and a health plan, where the health plan has performance measures and risk on an integrated basis versus an individual program basis. And under those programs, we're very focused on working with some of those health plans to bring that type of care model to market. I'll let Tom add to that.
Yeah, I think that most of the reimbursement would then come, as Mark said, at the payer side of it, and the contractual side of it. Where we're located, I mean, we're operating out of Rhode Island, which is probably the worst state in the country to be trying to do telehealth, because even in the rural regions, we're considered within a metropolitan statistical area. I will let folks know, if they don't already know, Medicare as of January has redefined how they designate an area as either being a metropolitan statistical or a health provider shortage area. And they have an online tool for determining that. They've relaxed it a little bit, recognizing that the definition was a little bit too tight, and that there were real needs regardless of those specific designations. But that said, it's still a fairly limited choices in terms of whether or not you qualify. For folks who are obviously out in the Midwest, it's a lot easier. Another source of funding, which I'm talking with my department about, has been whether the hospital, if any of you work in a hospital setting, has an incentive. As you know, most hospitals rely heavily on Medicare for the reimbursement, and they're now taking a Medicare penalty hit if they have rehospitalizations. And if some savings can be demonstrated by providing telehealth services to the high-risk patients who have recently come through the hospital, a portion of that savings could be allocated towards supporting telehealth if it can deliver on that. So that's another possibility as well.
Just one comment on the rural requirement from CMS. And for the Telehealth Resource Center, this is one of two major policy areas that I would just express an opinion. I think that requirement should just completely go away. And the example I'll give, we have a nursing home that is physically on the campus of Rhode Island Hospital. In other words, it's 100 yards away from the emergency department. And that nursing home often sends residents to the emergency department. And when they do, they have to call an ambulance because of risk and liability issues. And if we were able to connect that nursing home to the emergency department under the model we just described, we think we could reduce that number by anywhere from 30 to 70% on the high end. And Medicaid and Medicare are paying for those services. And because we're not rural, we're not able to make that work. And it has nothing to do with the fact that we're in a rural area. It's that these patients or these residents are difficult to move. There's risk involved in moving them. And, that whole requirement, I think, really needs to be rethought. And the second big policy issue is the whole interstate licensure discussion, which, as folks on this call are probably aware, there's a lot going on. What I will say is in Department of Defense and in the VA, there's already precedent that is a physician licensed in one state can see a patient in another state if they're within the DOD or VA system, because it's a federal program, as long as they're credentialed by DOD or VA. There's an argument to be made that Medicare is a federal program, and it's an interstate program, and that a provider should be able to be licensed by Medicare and see patients across state lines. I know that's controversial, and there's all kinds of debate going on the topic, but those are two, I think, major policy issues that could really help the industry if we can get over the rural requirement and the interstate licensure requirement. So with that, I guess that's a good way to throw it back at the Telehealth Resource Center if you want to wrap up.
Oh, by the way, I'm sorry, Mark. I'll throw in one other thing. I don't know if everyone's aware of this, just in case you're not. The Federation of State Medical Boards have recently got has recently approved the notion that a professional patient relationship can be established solely by telemedicine, which is big news because prior to that, certainly at the state level, and I think across states and nationally, there's been a real question ethically about whether you can establish a patient-provider relationship without having them come into your office and meet you in person. And so this medical board, at least at the federal level, paves the way for that. Of course, each of the states needs to adopt it and decide whether they're going to adopt it. But that's a little bit of good news. So with that, I'll hand it over.
Well, and we like to end on good news, right? So that's a fantastic point, and thank you for sharing that. And Mark, thank you so much for sharing your ideas around policy. In fact, I'm located in Maine and help out with the Maine Telehealth Forum, and we were having that exact same discussion. And who do we need to have in the room to make the designations a thing of the past, so that we're just able to use telehealth as another way to offer high quality care and to get people the access that they need when they need it, to streamline services, to not put people at risk unnecessarily. So fantastic points. I agree wholeheartedly. We are working on it. As you all know, and you had mentioned, things are so different state to state. So just trying to stay abreast of what's going on policy-wise and leveraging what we do have for great resources in each one of those states.
We appreciate the effort. It's much, it's needed that groups like yours are out there advocating it. It really is. So thank you. And thanks for the opportunity today. And I guess all our emails are online if anybody wants to talk.
They sure are. So I think I had muted pretty much everyone. So I'm going to go ahead and unmute everyone just in case you have any, thing to say, if you just want to say goodbye or whatever. That's great. But thank you so much, Dr. Sheeran and Mr. Mark Treat, and thank you to all of our participants. We really appreciate you being here, and we hope that you find this webinar helpful.
Figure out their panel. What are some formulas for that? And
it sounds like we are ready to close. Have a great afternoon, everyone.
Okay, thank you.
Thanks, everyone.
Bye.